Hello, I'm Dr. Russel Libby, and I welcome you to the world of medicine. You know, on the show, we explore important and interesting topics in healthcare and medicine to help you understand what's going on in the currents of healthcare today. We have with us some very highly placed individuals who are willing and ready to participate in the discussion I'm going to have with Dr. Leonard Goldstein. Now, Dr. Goldstein is a psychiatrist. He's one of the foremost authorities in that topic, in that healthcare topic in the area. Dr. Goldstein has been practicing here for close to 30 years. We're going to talk about mental health issues. We're going to talk about one of the problems in our country that probably goes under the radar incredibly. Somewhere close to 25% of our population in any given year will suffer from mental health issues that are somewhat disabling, whether it's anxiety, whether it's depression, whether it's related to a situation, or whether it's something that's chronic and ongoing. It impacts their quality of life, whether they can go to work, whether they can go to school, how they relate to their loved ones, their family, their spouse, whoever it might be. It can really impact the life, and it creates an incredible burden on our society. And a society that doesn't necessarily always recognize or want to acknowledge that this is an issue. It's a society where we often have access difficulties. We can't get the kind of care that we need, and if we can get that kind of care, we can't pay for it, and it's not something that people accept as an easy thing to deal with. So we're going to talk about mental health issues. We're going to learn about a lot of the different diagnoses that people might have. We're going to learn about where they come from, how people might know they have them, and what people might do to start to work on them themselves. Dr. Goldstein, once again, knowing you for many years here in the community, it's a great honor to have you on the show. Give us a little setup in terms of mental health issues as you see it from the mental health professional point of view.
First of all, thank you for asking me back, and it's a pleasure to be here. Pleasure to see you. You know, psychiatric disorders often are seen as somehow different from other medical issues. But everyone has genetic vulnerability. You know, some people get high blood pressure no matter what. Some people get diabetes. Some people get certain types of cancer, heart disease. And the brain is no different. And in the emotional brain, which is actually in the middle of the brain and in the base, it's actually the oldest part of the brain, and it predates mankind. And oftentimes, if people can find out about blood relatives, there'll be markers, whether it's somebody who had temper problems or mood trouble or worry or alcohol trouble. And that often will tie into indicating that someone may be vulnerable. In any case, the real kind of paradox about psychiatric illness is that most chronic illnesses start later in life, 50s, whatever. So you have a very long healthy interval before somebody gets sick. Psychiatric illness generally starts by the age of 14, about 40% of the time, frequently around puberty, and 85% of the time prior to the age of 22. So it's really the chronic illness of the young. If it's diagnosed early on and treated early on, it's really not a big deal, generally. However, the rate of diagnosis is often abysmal. In fact, take bipolar disorder, which is manic depressive illness, highs and lows, whatever. The average age of onset is 20. The average age of diagnosis is 40. 20 years. So you have a treatable illness that unfortunately doesn't oftentimes get diagnosed, so it does a lot of damage. In fact, depression is the second leading cause of disability in the United States and Europe, and will be second worldwide by 2020, according to World Health. The sad part of it is that although the healthcare funding has increased every year for many years, the behavioral health piece is roughly 40% of what it was 15 years ago. It leads to untreated, it leads to disability, it leads to legal trouble, it leads to divorces, it leads to trauma, because someone who's suffered trauma, if they have kids frequently, they wind up repeating it. And it's a very prevalent illnesses. And as you said, it's probably lifetime close to 50%.
Right. Well, you're bringing up some really interesting points that people sometimes don't perceive. And I think looking at something like diabetes from a medical point of view, and we've talked about diabetes on our shows before, and we've talked about kidney disease, for instance. All these kinds of things are gradual, slow processes that over time, without treatment especially, sort of increase the significance, the burden of disease. Mm-hmm. And you're saying that basically mental health issues, diagnoses that really can be caught early, often go untreated and create incredible combinations of problems. You know, like diabetes will give you eye problems, kidney problems, heart problems, all those things related to having had the diabetes that if you'd only known and taken care of early on, that you could have avoided a lot of those complications and had a much happier life. You know, you're talking also about the productivity issues and the disability that it creates. I've seen estimates that depression itself creates an incredible number, something like in the 1 billion days per year mm-hmm. of productivity and missed work.
That's correct.
1 billion days. I mean, that's an incredible human toll.
That's correct. And, you know, it's mentioning depression. And it's not just depression, but to talk about depression as an example, the first episode of depression generally is preceded by a fairly significant stressor. So you have genetic vulnerability, puberty, whatever, but generally there's a loss or some major stress. By the third episode, there's no statistical relationship between onset of a depressive episode and external events. Why? Because every time you have an episode, your brain changes. And at some point it becomes, it's superfluous what's going on externally because the vulnerability gets worse.
Right.
Untreated depression on autopsy shows atrophy and cell death in certain areas of the brain. Bipolar disorder, same. Schizophrenia, same. In fact, with treatment, that reverses in most cases. So we're not just really talking about quality of life and illness burden, but you're talking about, in the absence of adequate treatment, a progressive deterioration. And in fact, some of the medications that we use to treat some of these things, in fact, as it turns out, keep the brain young. There's a cohort of patients on lithium that are in their 80s now. The incidence of dementia in that group is 1/1000th wow. that are on lithium mm-hmm. of the general population. And as it turns out, that's because what lithium does is it turns on a certain chemical in the brain that keeps brain cells young. So
interesting that you're talking about it in that way because, you know, once again, we were talking about the chronic medical diseases, how they parallel, but you also have neurological diseases that parallel what you're describing, and ones that people may be more familiar with, Parkinson's disease, a movement disorder, mm-hmm. not necessarily associated with psychiatric issues, but to to some extent, but not nearly as you would expect with the depression or anything, or Alzheimer's, you see cell death in certain parts of the brain. They're involved in motor movements, and I guess you could say that's a real distinct parallel. It just depends on what part of the brain is affected by this. And we know that so much of it is genetic. I mean, there is a significant component. And I guess sort of, you know, there's so many places we could go to from that point of view, but let's talk about depression a little bit. You know, everybody will get down from time to time. You know, whether you're a kid who, you know, has their favorite pet dog and doesn't understand why when they turn 16 they can't live forever, the dog, I mean. But, and they go through 3 days of crying, not wanting to go to school. Is that a depressive episode? Yeah, I think you'd say that it was a situation. When you're an adolescent and, you know, your heart gets broken by the person who jilts you, you know, is that depression?
No.
That's not depression. We've got the authority now telling us that.
Depression is, it's a syndrome, and it's fairly easy to distinguish from situational factors. Okay? Or say mourning or grief. Number one, you have to have one of two things. You have to have sad a good part of the day, most days, for 2 weeks or more. Or you have to have loss of interest in usually enjoyable activities a good part of the day, most days, for at least 2 weeks or more. Now, in most people that have depression, it lasts a lot longer than 2 weeks. And it can last months in some patients. Also, you'll see that their mood trouble and their symptoms, which include sadness, loss of interest, loss of energy, increased sleep, insomnia, loss of appetite, increased appetite, suicidal thoughts, tearfulness, etc., anxiety, pain, somatic pain. What you'll see is, A, it's not like in one area. For example, well, whenever I'm at home, I feel depressed, but at school I'm fine, and here I'm fine. It's not like that. It's not fixable by changing the environment. And it happens, when it happens, it lasts for weeks, and it happens fairly frequently. And it's independent of what's really going on. So over time, it's quite easy to distinguish. The other thing, which is very important, is in psychiatric illness, if you have a very expert senior psychiatrist who asks all the right questions, talks to the patient, the accuracy of diagnosis is approximately 45%. If the psychiatrist talks to the patient and somebody who knows the patient, it's 95%. There's a classic tape that was done at Washington University in St. Louis. It was a bipolar disorder study. It was a tape. But there's this one scene where there's a guy who happened to be the patient and the spouse, and the psychiatrist is asking the gentleman, do you have racing thoughts? You know, do you talk fast? Are you impulsive? Do you get abnormally irritable, abnormally happy, etc.? And the guy's saying, no, not really, no, not really. And meanwhile, you see the wife is starting to like kind of squirm and make faces. And finally, she can't contain herself. And she says, dear, remember when Johnny was in high school and you were going to write the great American novel and you told your boss to stick it and you got fired and you would stay up all kinds of hours of the day and night and you spent all this money and you were like ecstatic and thought you were going to, you know, be, you know, a #1 on the New York Times bestseller list? And the guy looks at her and goes, is that what the doctor meant? I mean, this guy, he wasn't lying. He just didn't see it that way. And oftentimes the other person sees it much sooner. And because when you feel bad, you don't want to feel bad. So you tend to try and cope with it and minimize it, and oh, it'll go away. Oh, it's because, you know, I had a bad day. It's because of this, because of that. And until it gets severe, which is when people are like, something's horribly wrong with me, you know, and they start thinking about it, I'd be better off dead. But, you know, a lot of people don't have severe episodes, at least not early on. So they can, and especially people that have some resilience and have strength, you know, most people have strengths, they can cope with it. The problem is, A, you don't have to cope with it, and B, over time, it's doing a number on your brain.
Right. So interesting, just to start off, is that there are situations that people think they're depressed, and they like to talk about, well, I'm depressed today. They just like talking about it. Just by virtue of the fact that they like to talk to you about it probably means that it's not so bad after all. But nonetheless, there are those situations. Now, there must be some evolution through time that allows them to get to the point where their general attitude, their approach, and their expectations start to get, let's say, jaded by this negative expectation.
Well,
and
there's
sadness.
psychological consequences of having the illness called depression.
Right.
And it does affect how you think. You tend to think more negatively. You tend to have a sense of the future is not going to be so good. One often tends to, criticize themselves. I'm no good. I'm stupid. And that follows. And one of the treatments for depression is a type of talk therapy where you help the person change how they think. Because oftentimes these thoughts are very unrealistic, inaccurate, not helpful. And it's worth talking also about anxiety disorders, if I may.
Sure, I think we have to talk about them.
Well, frequently when we see somebody with an episode of depression, and you get a history, it turns out that they've had a lot of anxiety difficulties for a long time. Say they're in their 30s and this is their first major episode of depression. But if you ask them, are you a worrier? Do you find things to worry about? Were you an anxious kid? Frequently, the answer is yes. And as it turns out, 80% of people that have an anxiety disorder will have at least one depressive episode. And we think it's because it's genetically very similar or the same, and that it's expressed phenotypically, which in essence is like a flower that has the same gene, but one of them is pink and one of them is white. And anxiety and depression can very much be like that. And so oftentimes in retrospect, the person kind of sees it for the first time. The good news is there are very good treatments. So,
just lingering a little bit more on that diagnosis, and it's important. I think that people sometimes think, okay, I'm depressed, but they don't really acknowledge it. They really don't know how to accept it in themselves, accept that they feel down or negative. But usually it is someone around them who says, you're not doing anything, you're not getting your work done, you're sleeping too late, you're wandering around the house in the middle of the night, what's going on? I ask you questions, you don't answer with any kind of excitement, nothing that should be making you drive through life is doing that anymore. But are there also precipitating events? I mean, people can have what you call, a dysthymic disorder, which is sort of a depression light of sorts, just not quite as intense or disabling. And what I want to get to is there are other experiences that are still in the psychiatric spectrum that precipitate them. Is PTSD, post-traumatic stress disorder? I mean, is that something that sometimes creates the backdrop against which a depressive episode might occur? Things of that nature?
That's a very important, actually, point. You have genetics. Okay. Then you have the first 3 years of life. Bonding, the maternal-infant interaction is incredibly important. And if I can do a little sidebar for a minute, there's a part of the emotional brain, it's called the amygdala, for what it's worth. It's the panic button of the brain. It's hardwired, and it's the fight-flight response, okay? The caveman sees the bear, either he runs away or he kills the bear or the bear kills him, okay? And it's hardwired so that it's an instantaneous thing. Because if there's a grizzly bear standing nearby you and you say, let me think this through. Perhaps I should, you're dead. Right. So it's a very instant reaction. And bear with me because this gets a little complicated, but in the first 3 years of life especially, if you're born with a sensitive amygdala, an anxious kid, it can be buffered and the actual DNA changes and you can reset it. Conversely, if you're a baby and you have a normal amygdala and you got an environment in which your caretaker is, you're sitting there, you know, like doing your thing and the parent goes, "What are you doing?" You can create an anxious kid, okay? So early in life, you can influence this. Similarly, trauma, physical abuse, sexual abuse, any kind of trauma, and the earlier it occurs, the more it can set the stage and cause vulnerability, even without the genetic. And if you have that, and then you re-experience it 20 years later, that's similar, it can precipitate not just a re-experiencing of the trauma, but it can lead to other symptoms like a depressive disorder. The other thing about this that's important is the cerebral cortex, which is, you know, the thing that helps us think and talk and think symbolically, like, you know, what
separates us from most animals?
What's this
in nature, right? Right.
It's nothing. I mean, it's a piece of paper. It has no inherent value, but to us, it's $1.
Right.
Well, the old brain, the emotional brain, that's old. The cortex is a relatively new thing. It sort of just popped up like kind of a mutation. So the connections between the old brain and the new brain, they're not so good. So not only can we have a fight-flight response to a grizzly bear, we can have a fight-flight response to a red light, to somebody cutting us off, to getting an envelope that says the IRS. And even though intellectually we know it's not life or death, we're reacting inside like it's life or death. And if that goes unchecked, it's not so good for you. And that's sort of what's happening with a panic attack or an anxiety disorder or a phobia. That person is reacting just like somebody who's confronted with a life or death situation, except it's not a life or death situation. And with medication and with certain types of therapy for trauma or for anxiety disorders or depression, you can get the person well and keep them well, because being partly better is not good.
You know, I mean, obviously you keep opening doors, and this seems like an endless hall. There are a lot of interesting things to talk about from the point of view of a mother and their child, and postpartum depression being something that exists in a very significant number of women, all attended to that time towards the end of pregnancy and after but seemingly getting worse in those 6 to 8 weeks after delivery, but still most significant for those who have some predisposition to depression. And they create a milieu, not only from their genetic contribution, but by virtue of their actions and their behavior on a baby. And is that something that contributes to the overall outcome as well?
Well, as you know, as in your own work as a pediatrician, probably the most stark example is something called anaclitic depression. Infants attached usually to the mother, and separation and what's called separation and individuation, the psychological birth of the human infant, occurs at 18 months, 2 years, 3 years. Now, if you take a 1-year-old who's attached and the mom goes away, dies, some kids develop what's called an anaclitic depression. They won't eat, they can't be soothed, and they die, some of them. That's the most extreme example. But yeah, pregnancy is a very high-risk time for women as far as mood disorders. And I'll tell you a quick funny story about that, but if someone develops a postpartum depression, can't bond, may get to the point where they don't want the kid around, or God forbid, you know, they get suicidal and they think they're going to take the kid with them and all that stuff. But it's very destructive to the mother, to the family, and obviously to the infant. And it can really interfere with the kid's development for years to come. The story I was going to tell you is I have a patient who was on medication for her depression. And, am I okay?
Oh, you're just flicking your mic.
Okay. Is it all right?
Got to be careful with those things.
Okay. Anyway, she decides they're going to get pregnant, and she wants to go off the medicine, and she does. A year goes by, no pregnancy. She feels not so good, by the way, also, because she's not taking the medicine. Then they do in vitro. A year later, 2 years now, she comes back and says, I've had it, I'm not pregnant, and I'm depressed. Give me my medicine. So she goes back on her medicine. I see her a month, 5 weeks later, she's pregnant. And she said, the body has a way of taking care of itself, meaning when women are depressed and pregnant, their pregnancy is much more difficult. It has an impact on the kid. And today, most OBGYNs lean towards leaving women on their medication because of that.
And we know we could talk a lot about medication and the virtues of medication and the difficulty that clinicians have dealing with the media and the hysteria that comes around surrounding medications. But we'll save that for a couple of minutes later in the show. So we talked about depression. We understand that it often has its roots in some fairly primal genetic background, and that it can evolve through the childhood experiences, but then be precipitated in that 20 to 30 or 40-year range, and then become rather catastrophic, disabling in their lives. Anxiety disorder, another one that's probably even more common. I mean, to the point where, 20% of the population has some form of a diagnosable or identifiable anxiety disorder. How do people, you know, everybody feels anxious. Oh, I don't like to talk in public. I'm worried about, you know, having a nightlight on it. You know, things of that nature. Everybody thinks, well, gee, I know the floor is not the ocean with sharks, but for some reason, ever since I was a kid, I always had this fantasy. Anxiety, you know, where does it come from, and when is it really a disorder?
Mm-hmm. Yeah. First of all, these terms are, in some sense, obsolete. If you start with the emotional brain and the different pathways and centers, there's a lot of overlap, but just to answer your question, the quote-unquote anxiety disorders, there's a number of specific anxiety disorders. There's generalized anxiety disorder. This is the syndrome of worry. People that find things to worry about, even when there's nothing to worry about. They will generally say they feel anxious or worried a good part of the day, frequently, most days. They may have physical symptoms, sweaty palms, lump in the throat, diarrhea, sweating, stuff like that. But it's sort of a chronic, it just starts early on and it continues. Then you have something that's called panic disorder. Panic disorder is out of nowhere, not related to any specific situation. Someone begins to feel terrible. They will often feel faint. Their heart may race. They may have pounding, palpitations, chest pain. Frequently they'll feel like I'm having a heart attack, or I'm losing my mind, or I'm going to lose control. They may have numbness or tingling in their hands and feet, sweating, vertigo. It lasts generally 5 minutes, maybe 3 minutes. However, once you have one, very predictably you develop what we call the what-if disease. What if it happens again? What if I'm on the Beltway and I get one? What if I'm in the meeting and it happens? So they start to worry about situations where they will have a panic attack from which escape would be impossible or embarrassing. So then they start to avoid things, or they endure them with distress. Crowds, planes, etc. And that can lead to panic disorder with agoraphobia, which at its worst means a fear of leaving the house, being outside by yourself. So we have generalized anxiety, we have panic disorder. Then we have post-traumatic stress disorder. This is when someone has experienced something that life-threatening or extremely dangerous, or witnessed it, and they begin to have nightmares about it. They re-experience it. If something reminds them of it, they feel like it's happening again. They may feel a dulling of their emotional range. They may feel guilty about surviving. But generally, it's clear that there was a significant traumatic event. Phobias, which feel exactly like a panic attack, the only difference is it's in response to the phobic thing. Being on an elevator, snakes, bridges, your tie. And there's a famous case of somebody who was phobic against the color green, and the therapist used it's a long story and I won't tell it, but basically as part of the therapy, they got to the point where he could wear a green tie, and everybody got better. Other anxiety disorders, obsessive compulsive disorder, not usually thought of as an anxiety disorder, but it is. And this is repetitive unwanted thoughts and intrusive unwanted thoughts, repetitive over and over again, or repetitive unwanted behaviors. For example, contamination fears leading to compulsively washing. Not washing a couple of times, but I have to wash my hands a certain way 10 times in a row. And if I don't do it exactly the right way, I have to start over. Or taking, spending 3 hours a day in the shower. Checking locks, appliances, not a couple of times, but almost a ritualistic, so that it's hard to get to work because you have to do it so much. Counting. people who feel compelled to count. Like they step on a crack in the sidewalk, so they have to do a certain repetitive act to prevent something bad from happening. Neatness, not neatness, but if they see something uneven, they have to make it even, or they have to touch their fingers a certain number of times evenly, or rub things a certain way. And it can become very disabling. I mean, you've heard of the people that can't throw things away. Right. That's a part of that, where they, will fill their apartments or houses with magazines or.
Interesting. I mean, certainly there are so many things that come to mind when you start to talk like that. When I think of people like that, many people would think, well, I'm going to go through it. I'm going to look through it. Is it something that they're afraid they're going to lose? That's an important part of them that they just aren't aware they could throw away? Is it that fear
of hoarders?
Yeah.
The hoarding starts out usually with, I might need it, I might want to read it.
Right.
But
innocent.
It goes way beyond that, and they become panicky if they try to get rid of it or somebody else tries to get rid of it. And once in a while you hear the health department was called because this apartment stunk and there was filled with, all sorts of things. That's typically a hoarder.
Interesting that you say that. I think a lot of people are hoarders. There's a relative degree of hoarding that episodically people will clean things out, get rid of them, and not have carry it like excess baggage per se. But most people will get upset if somebody else decides they're going to do it for them. But it doesn't persist in a way that creates the kind of distress. It may be an uncomfortable moment when somebody accuses you of doing something they didn't want you to do. But at what point does that kind of symptom become more?
This is really not about the hoarding. It's about spending a lot of time to the point where it interferes or it causes you distress, hours a day, and it has to be associated with very significant anxiety in terms of in this case, getting rid of the stuff, okay? So for example, somebody who can't touch doorknobs, they shower all the time, they're constantly afraid of contaminating others and causing harm to others. The way we treat them, one of the main techniques is behavior therapy, where we will teach them to relax. Then we'll say, okay, think about someone else being muddy. And they'll get a little nervous and we'll get them to relax. And then very, very gradually, we'll move up the hierarchy and eventually expose them and actually have them sticking their hands in, like a mop pail, and tolerating it.
Right. And it's something that seems to many people probably to be almost hard to believe that someone could have to evolve to that point. I would think the media probably feeds into this with the MRSA scares and the general attitude that they take towards, exposing people's anxieties in ways that are totally insensitive to those who might be severely affected by it.
I probably shouldn't say this, but for a lot of my patients that have trauma issues and worriers or they've been traumatized, I confess to them that I don't read the front page, I don't watch the news, I don't go to movies that have horrible things in them because I've heard so much about this stuff. I don't need that in my brain, and neither do you, I tell them. So, I think there's a lot of commercial ventures, media, magazines, etc., that it's profitable to sell stuff like that. The news story of the horrible thing that happened, or
it's intriguing. It gets people who want to participate in the experience even though it may cause them tremendous anxiety and disrupt their sense of equanimity.
I think, you know, it's sort of like a lot of things. In the moment, it seems appealing,
Right.
but afterwards, you pay for it.
Right. Yeah, it's like Lecter, or Hannibal Lecter, that's it. And you can't help but think about some of those scenes, even if you don't want to. They play over and over again in your mind. And if you have a mind that tends to overemphasize that, the obsession, I guess, can really disable you. Make you feel very bad.
You know, when we are, this is probably way off topic, but we're hypnotized when we watch TV and movies. We're in trance. We're open. And we don't realize it. And this stuff is coming in.
Right.
And, you know, it's no big shock that, gee, I had nightmares for 3 nights after I went to that movie.
And we have some built-in filters. I mean, we can separate reality. When you look at some of the population who spends hours a day, kids, sitting in front of a television, getting that kind of information, that kind of visual reinforcement, it can create a lot of anxiety, I would think.
Well, I guess we'll find out. I mean, if you look at the evolution of the video games over the years, they're fairly violent and sometimes sadistic, and you know, show all sorts of things. And it's if you've ever played a video game, it's very many people, after they've played one for a while, you know, a couple of hours, they say they, you know, when they close their eyes, they see, like, you know, trails. And I mean, it's not a benign.
Right. Well, and then once again, you add to it influencing a brain at a point where it's much more impressionable and vulnerable. You know, you've been talking along the way about medication, and I always think it's really important to mention, because what'll happen. Well, you take antidepressants, for instance, and you're talking about depression, and that nothing is more useful in the course of a program to treat depression than a medication, that you do have therapy and you have other endeavors that help to reintegrate or to elevate a person so that they aren't afflicted in a way that does make them disabled. But medications are a big part of it. Yet the media will emphasize any negative study or any statement that someone in some authoritative position might make, and make it seem that now they're no good and you can't use them. They did this with antidepressants in adolescent suicide a few years ago, one that has resulted in a rather disappointing outcome, which is that now we realize that during that time fewer people were diagnosed, fewer people were treated, and the adolescent suicide rate has increased dramatically, something like 40% during that period of time, really indicating undertreatment. Give us a little perspective on medicines and how important they are in the course of treating these things.
Well, I don't think most people would have a strong opinion about neurosurgical techniques if they had a brain tumor. And I don't think they'd have strong opinions about chemotherapy versus radiation if they had cancer. And if their blood sugar was out of control and they were at risk of losing their sight or their limbs, it's hard to imagine they would go on the internet or watch a TV show and insist on, I'm not doing that. It's only in psychiatry where everybody sort of has an opinion. You know, I wouldn't argue with a quantum physicist about quarks or black holes, but it seems like everybody thinks that they know a lot about this stuff. But if you think about the fact that the science is very good, we know that there are genetic vulnerabilities in a lot of chronic illnesses. What we do is we suspect someone has, say, depression. What I tell them is, look, until I can prove by pinpointing the pathway, and you will know it because you're going to feel normal instead of depressed, I can tell you I think that's what it is, but we need to go through a systematic process. I'm not going to say, here, try this and come back in 3 months. And generally what I'm doing early on is I may quickly, depending on how the patient responds, try one of several medications because this one works on the serotonin pathway, and this one works on the norepinephrine pathway, and this one works on the nucleus. And I tell them it doesn't matter if it doesn't work, because I'm getting information about how your brain is wired, and the proof's in the pudding. And if you're starting with some vulnerability, what you're doing is repairing it. You could go through life coping with the vulnerability, or you could get rid of it. So, I mean, if you're hypothyroid, do you want to just feel cold and dumb and gain weight and lose your hair? Or do you want to fix the vulnerability so that all that goes away? You know? It's no different. I mean, it's the same as any other organ system, except 80% of what goes on below the neck starts above the neck. So it's kind of important.
Right.
So, you know, I think when you present it that way and you involve the patient and there's good communication and they understand that I tell people 2 things about meds. Number 1, 2 rules. No side effects, works good.
Right.
So if we can't do that, I'm not going to ask you to take something for months and months.
Years.
So.
Yeah, and I think that people have an innate fear that they're going to take something that's going to change their personality.
Mm-hmm. In some cases that might be a good thing.
Right, I'm sure that. They have anxiety that the possibility of side effects could be very detrimental and permanent. And they come in with the preconceived notions. Mm-hmm. And I think it's just important to be able to emphasize that self-medication, people who turn to alcohol, people who turn to illicit drug use, isn't really the same as specific medications. They don't necessarily mean the same. It's not like people have an innate understanding of what their brain needs. Those substances are poor substitutes for an appropriate medication.
2 things about that. If somebody comes in and says, I want to take Prozac, I'm going to try and meet the person where they are. You know, talk to them. I'll say, I think you have an anxiety disorder or a mood disorder. I think an antidepressant makes sense. I personally wouldn't recommend Prozac for the following reasons, but we could try that first. And if it works well, great. But remember, no side effects, works well, you get well, you stay well. That's the goal. Prozac might not do that, but we could start there. So that's one thing. So it's very important to meet the person where they are. Number 2, when the dopamine genes were mapped, what they discovered was there were 2 dopamine genes that had a certain characteristic. If you had one of those characteristics on one of your dopamine genes, your odds of being addicted to some substance, smoking cigarettes, being obese, being depressed, or having ADD was like 7% higher than the population, general population. If you had it on the other one, it was like 6%. So they looked at people who had it on both, and then they did a family study, and they looked at blood relatives. Over 70% of the blood relatives had obesity, had smoked at one time, alcohol trouble, heroin, ADD, depression. So, and when they took these vulnerable people, like they took the obese people, and they did a PET scan, which shows uptake in certain areas of the brain, and when they would overeat, that area would light up. The smokers, when they smoked, that area would, so they were self-medicating to correct the vulnerability. the dopamine problem. As you point out, works a lot better, and it's a lot healthier to take a drug like Wellbutrin, which turns on dopamine. You don't have to eat a ton of stuff and get fat. You don't have to smoke cigarettes. You don't have to shoot heroin or drink a pint of vodka every day. And it's a lot cheaper.
Ultimately, yeah, and you can live a lot longer and a lot more healthy life as well.
So that often tips us off, that kind of thing.
Right. And I guess there's that element of people not knowing the clear pattern in their family histories. I think there are a lot of our population really weren't exposed to the organized approach to diagnosing or the exposure that people might have needed to be able to understand that there was something that a relative might have had. There was grandma who would always stay in the kitchen, would never come out, whatever it was, or Uncle Ned who committed suicide when he was 35.
Yeah, and you get back one generation and the information's not very reliable. I mean, who knows about their great-grandparents? Plus, people are adopted.
Right. A lot of people.
So.
Getting into a subject that probably we could do a whole show on, ADHD. It's certainly a buzzword, and certainly it's got a lot of press for any number of reasons, but one in particular is that we've created an educational expectation in our society that has kids conforming to certain types of classroom settings and having to acquire a certain set of knowledge to be able to move forward. And many parents will have kids who bona fide have a real ADHD diagnosis, and many of them will have kids who don't, but they really like to be able to diagnose them as such so they can treat them. And then you have a lot who have kids that way and refuse to accept that as a possible diagnosis. Then you have adults who grew up that way and never knew until they're having miserable times as adults and failing. Give us a little biological perspective on ADHD.
Well, again, it's it's in the same general area. It's in the prefrontal cortex. Not that that carries a lot of meaning to anybody, but in terms of, and we see this a lot in the hospital with adolescents and adults, and we always ask, when you were in grade school, because this starts early, doesn't start when you're 20, it starts in childhood. And there's a series of questions. Did you have trouble paying attention in class? When you read things, did you frequently find you had to reread things because you didn't remember what you just read? Did you have trouble staying in your seat? Did you feel impatient inside? Did you blurt things out? Were you forgetful? Were you disorganized? Did you have trouble sustaining attention with detailed or boring work? And there's 20 or 30 questions that we routinely ask. When you go through it systematically, as I know you do, and I know you have to deal with you examine the kid and it's really not clear-cut ADD, but you got the family who wants to think it is because they think they want their kid to get straight A's or whatever. Sure. But I really think it's, despite the fact that it's much more, people know about it more, et cetera, it's still undertreated. It's still undertreated. I mean, I see people every day in the hospital who are admitted after a suicide attempt, say, or whatever, who are in their teens or in their 30s, or they're depressed. And you ask them, and it's clear as day, they've never been diagnosed, they've never been treated, and it makes an unbelievable difference. I had a guy who came in, he was in his probably 35 or so, he was a stockbroker, multitask, because he couldn't, but he was good at it. And, his father always told him he was stupid. And it was very poignant because when it became obvious he had ADD, number one, we put him on meds. It was like dramatic. then he had his dad come in, and you know, we sort of talked through it. Dad broke down, was crying. He had ADD.
Of course.
And the epilogue was the guy went to law school. But after he was like so free of this problem and was so happy, then he was really sad about all the time that he didn't, you know, he had to live with it.
Right.
Not depressed.
Right.
Just he had to grieve that. It's a very dramatic, it can be very dramatic because people do put up with it. You know, I see people in the hospital all the time and in my office who see themselves as kind of losers. I'm not good in school, I got a GED or I dropped out. And it becomes obvious when you examine them that they have incredible, you know, ADD problems. And it's like a life-changing experience.
Yeah, intellectually, they can be quite normal. You know, as we come down to the fine last minute or so of the show,
2-minute one.
access to health care, access to managed behavioral health. I mean, these are all issues. You know, people don't understand. They have insurance policies. They can't just go to a psychiatrist. They have to call a mental health unit and get approval to go do that. If they're lucky, they can find someone who's worthy of their time, such as you.
It's, you know, I was having a good time until you mentioned that. Now I'm starting to get angry because it's really bad.
It is bad.
It costs our society billions and billions. People in jail, people unemployed, divorce, violence, motor vehicle. I mean, it's unbelievable.
It is endless.
Yet we make it really hard to get care, to access care, plus the benefits are discriminatory.
Well, we're going to have to close it on that, but it's an important point to end on because you've heard a lot about mental health issues. You've come to realize that there is a huge population in this country that suffers and that there are ways to help and to make it better, and that it's an important thing to do just like any other disease. And we need all of you out there to really try your best to be advocates, to be active and seeking that kind of activism that's going to make a difference. And until the next time, I'm Dr. Russell Libby, looking out for your health.